Your thoughts create your reality. So if you want to win, you will have to first think and you will have to believe that you can. All the people who ever won, all the people who have changed this world are the ones who are crazy enough to think that they can. So believe in yourself. If you believe in it, you can be it. So with that, we start with another important topic of the year, and that is serous otitis media. Our aim will be to understand the concepts of serous otitis media, what exactly this is, so that we are able to answer all the questions, and if there is any patient, we'll be able to diagnose him and treat him accordingly. So what do you think is serous otitis media? What does the name tell you? Yes, the name tells you that it is a otitis media which has collection of serous fluid in it. It is also known as otitis media with effusion. So now that we know that this is otitis media where fluid has collected in the middle ear, where do you think the fluid has come from? Yes? Okay, so it has come because of eustachian tube blockade. The fluid has not, the normal secretions are not able to drain. Okay, so why eustachian tube blockade has occurred? Eustachian tube obstruction because of what? Because of infection? Infection? Think again. If it was infection, if it was pharyngitis which was leading to infection of the eustachian tube, and if infection was the cause of eustachian tube obstruction, it will lead to which condition of the middle ear? Yes, that will lead to acute otitis media. So this is a non-infective fluid that is collected in the middle ear. So this obstruction cannot be because of infection in the pharynx or infection in the eustachian tube. Then what is this obstruction? This obstruction is a non-infective obstruction of the eustachian tube. And what can be a non-infective obstruction of the eustachian tube? Yes, the most common cause is a non-infective mass where the eustachian tube opens. Where does it open? Yes, it opens just behind the nose in the part of the pharynx which is known as nasopharynx. We already know that. So if there is a non-infective mass here, then that is the most common cause of serous otitis media. So if there is a non-infective mass, what can this non-infective mass be? Yes, this non-infective mass most commonly is a hypertrophied adenoid. Most commonly, it is a hypertrophied adenoid. Hypertrophied adenoid, and adenoids are present in, yes, they're present in children. Are they present in us? They start to atrophy by puberty. They disappear by 20 years. Me, I don't have adenoid. You have? No? Okay, so which means that hypertrophied adenoid is present usually before 12 years of age. At puberty, they start to atrophy, which means that serous otitis media will be seen more commonly in children or in adults. Yes, it will be seen in children. And can you tell me that adenoid is a midline structure or is it a lateral structure? Yes, just see here. Yes, adenoid, where it is present, here we have both the ears. So adenoid is a midline structure in the nasopharynx, which means that it will obstruct one eustachian tube or both the eustachian tube. Yes, it will obstruct both the eustachian tube. So hypertrophied adenoid will lead to bilateral obstruction of eustachian tube, which means it will always lead to bilateral serous otitis media. But thankfully, we cannot have, right? Because we do not have adenoid. We do not have adenoid, yes or no? Yes. So we cannot have serous otitis media. True or false? False. Why? Because in us, we do not have adenoids, so the cause of serous otitis media in us will not be adenoid hypertrophy. Then it will be any other non-infective mass of the nasopharynx. So if it occurs in adults, then we have to rule out any other non-infective mass of the nasopharynx. And do you know what this non-infective mass in the nasopharynx can be in adults? It can be, yes, worse, a nasopharyngeal carcinoma. So in children, this is in children. Hypertrophied adenoids, this occurs in children. Whereas in adults, this mass can be a nasopharyngeal carcinoma. And yes, the nasopharyngeal carcinoma, it arises from just behind the eustachian tube from the lateral wall, which means that in adults, serous otitis media, which is because of nasopharyngeal carcinoma, is unilateral. It will be unilateral, yes. So what do we know as of now? Yes, what we know is that serous otitis media is collection of sterile fluid in the middle ear, and the cause of this collection of sterile fluid in the middle ear most commonly is a non-infective mass in the nasopharynx, and this non-infective mass in the nasopharynx of a child is most commonly a hypertrophied adenoid, because of which in children, if there is serous otitis media, it involves both the ears, whereas in adults this non-infective mass is a nasopharyngeal carcinoma, because of which any adult with unilateral serous otitis media, we have to rule out a non-infective nasopharyngeal mass. Which non-infective nasopharyngeal mass? A nasopharyngeal carcinoma. So can this be the only cause of serous otitis media? Can non-infective mass obstruction of the eustachian tube be the only cause of serous otitis media? So there can be there can be some other causes also. So what can be the other causes? There can be some causes which lead to other causes which lead to eustachian tube obstruction, that is malfunctioning of the muscles of the eustachian tube. For example, in cleft palate. You must be thinking cleft is in the palate. Why eustachian tube? The palate muscles, tensor palati, the levator palati, they are the muscles which open and close the eustachian tube. So if the palate is defective, it means the muscles of the palate is defective, which means that the functioning of eustachian tube will be defective. So if there is a cleft palate, if there is malfunctioning of the eustachian tube, that can, because of not proper functioning of the muscles, that can also lead to serous otitis media. Now also it can occur because of increased production, as in allergic condition. So what we are seeing is that the collection of fluid can be either because of decreased drainage, that is because of eustachian tube obstruction, or it can be because of increased production. Increased production occurs in allergic conditions. Also sometimes what happens in acute otitis media, you have given a patient antibiotics but in inadequate dose or duration. So what has happened is that the features of infection have subsided. Now the pain is not there, but the fluid is still there in the middle ear. The fluid has not completely resolved. So a acute otitis media which is unresolved can also lead to collection of serous fluid in the middle ear or serous otitis media. But these are not the very common causes. The most common in children is, quickly tell me, most common in children will be is hypertrophied adenoid. And in adults, if there is a mass, then the mass has to be a nasopharyngeal carcinoma. What has to be ruled out? A nasopharyngeal carcinoma. Okay, so now what will happen because of this mass? Yes, because of this mass, the eustachian tube will get blocked. So the secretions will not be able to come out. Also because of eustachian tube obstruction, there is negative pressure here. Because of negative pressure, there is transudation of fluid from the blood vessels into the middle ear. Because the pressure in the blood vessels becomes more than the middle ear pressure becomes negative. So now what has happened is that the fluid has collected in the middle ear. Okay, so this is what has happened. The cause why it is collected, we know. Now what has happened is fluid has collected. So what will be the complaint of this patient? This patient who has come to you, who has serous otitis media, fluid in the middle ear, will come to you with what complaint? Will there be pain in the ear? Pain in the ear. Is there a lot of infection in the middle ear? No. Is the fluid that is collected, is it in a lot of pressure? It is not in a lot of pressure also. Why not? Because the cause is a hypertrophied adenoid. Why does the adenoid hypertrophy? Yes, it hypertrophies usually in allergic conditions. And allergy, we know, it waxes and wanes. So sometimes adenoid size is more, sometimes it is less. Again, it is more sometimes. So what happens is that when it becomes less, some fluid drains out. Yes, so the fluid that is collected here is also not in a lot of pressure. So it is not putting pressure anywhere also. So the patient never has pain here. It is absolutely a painless condition. Okay, so what do we mean to say? Patient will come that I have no pain. What complaint? Yes, patient will have the only complaint, that is hearing loss. Because of fluid in the middle ear, patient will have hearing loss. So yes, the complaint will be hearing loss. And what hearing loss? Yes, in children, it will be bilateral. In adults, it will be unilateral. So any bilateral conductive hearing loss in a child should be investigated for serous otitis media. And how is the hearing loss here? Yes, as I told you that sometimes the fluid drains, and then when the size increases, the fluid collects again. So it is on and off. So what is that? This type of hearing loss? This is known as fluctuating hearing loss. So any bilateral, the presenting complaint in a child will be bilateral, painless, and very, very important, fluctuating hearing loss. And each and every word here is important, is a question of your example: bilateral, painless, and fluctuating. So this is how a child will present, and in adult it will be a unilateral, just no pain, painless conductive hearing loss. So many times the parents will come to you with a complaint that my child was fine maybe 5 days back, 1 week back, and suddenly since 1 week the child is not hearing. Not hearing means what? Yes, the child is not responding, mom is shouting, the child is not responding, teachers are complaining that the child is not responding, TV is at the maximum. So now they have made out that the child is not hearing properly, so they have come to you and they are telling you that whenever there is a season change, we have noticed that our child has this, we take him to the doctor and the doctor gives him some medicines and he's fine. Yes, so whenever there is any child who has come to you with this complaint, you know that only hearing loss. Yes. Any pain? Patients have complained? No. And you have a look at the child. You are seeing the child is sitting in front of you and he's just playing with everything on your table. He's just smiling at you. He does not even know that the parents are complaining about him, that the TV is maximum. He's not responding. So you know that most likely this is a child who will be having serous otitis media. Many of the times the parents get the child to you with a complaint that the child is not developing speech. Yes, so whenever the child is not developing speech, what is the thing that we need to rule out? Child will develop speech only when he hears. So whenever any child is not developing speech, if the parents are complaining that my child is not developing speech, so then you have to rule out whether the child is hearing properly or not. Yes, and when the parents come with this complaint, this is one thing because there's a bilateral condition. Yes, bilateral will lead to bilateral hearing loss. It will be painless. The child will not complain of anything. The only complaint might be that the child is not developing speech. So any child, parents who have got the child to you with a complaint that the child is not developing speech, always rule out hearing, always rule out a bilateral serous otitis media. So the other complaint can be delayed speech development. Delayed speech development. So now whenever the parents have got to you the child with these complaints, just with a bilateral painless hearing loss. Yes, so we know any bilateral painless hearing loss in a child should be investigated for, yes, for serous otitis media. So what you do is, now you immediately examine the ear of the patient. You have a look at the tympanic membrane. If this is serous otitis media, what do you think will be the appearance of tympanic membrane? Will it be dull or will it be congested? Yes? Yes, very good. It is not an infective condition. This will be a dull tympanic membrane. Will it be retracted or will it be bulging? Yes, we already saw that here what is the hearing loss? It is fluctuating because the size of the adenoid varies. So the fluid drains, collects. So it is never a bulging tympanic membrane. It is a dull and a retracted tympanic membrane. So yes, the tympanic membrane appearance will be a dull and retracted tympanic membrane. Can you see the tympanic membrane and tell that this is a retracted tympanic membrane? Can you quickly tell me what on the tympanic membrane tells you that this tympanic membrane is retracted? What are the findings of retracted tympanic membrane? Yes, very good. First, the handle of malleus will be foreshortened. Yes, the lateral process will be very prominent. The malleolar folds will be a little prominent. Yes, the cone of light will be distorted. Here it is not too much distorted. It is the early retraction that you are seeing here. Yes, and you are seeing that the tympanic membrane appears so dull. And many a times, what the appearance that you see is the appearance like this, where you can see bubbles. You can see bubbles behind the tympanic membrane. Sometimes you are able to see the fluid level, air fluid level. Air fluid level. Yes, why bubbles are seen? Yes, because the eustachian tube is not completely blocked. So sometimes when the air enters into the eustachian tube, there already is fluid in the middle here. So that will lead to bubbles formation. So can you see here again, this is a retracted tympanic membrane. The handle of malleus is foreshortened. The lateral process is a little prominent. And what grade of retraction is this? Grade 1. Yes, there's a grade 1 retraction. And also tell me what classification is that? Is it a TOS classification or SADE classification? Yes, you have to remember whatever you have learned earlier. Yes, we did this. The retractions we have already done. Yes, that is of the pars tensa. It is what is known as a SADE classification. So this is a grade 1 retraction that you're seeing. Many a times what happens if the eustachian tube is blocked for a very long time? The fluid in the middle ear precipitates. And that precipitation of the fluid of the middle ear, the cholesterol crystals which are present in the middle ear fluid, they precipitate, and that leads to the formation of cholesterol granuloma, and that gives the tympanic membrane a bluish appearance. Can you see a little bluish appearance here? So that happens because of precipitation of the cholesterol in the fluid of the middle ear. So that is what is known as cholesterol granuloma. It forms cholesterol granuloma, and that gives the tympanic membrane a bluish appearance. So, and because it is because of chronic eustachian tube obstruction, the fluid in the middle ear becomes very thick. That is why the serous otitis media is also known as glue ear. So what you can remember is glue is blue. Glue ear, serous otitis media is bluish tympanic membrane. Not always, but yes, because in your exam it is asked that bluish tympanic membrane can be a feature of. So yes, it can be a feature of serous otitis media. So it is glue ear. Now here, please note this. Yes, see this tympanic membrane. Can you see how dark blue this is? Yes, this is the appearance of a hemotympanum. Please don't confuse this with serous otitis media. This is hemotympanum. Blood has collected behind the tympanic membrane and fracture of the temporal bone. This is hemotympanum, whereas this is a light, a dull, a retracted tympanic membrane, which is appearing bluish, and usually the appearance is with air bubbles and fluid level. So this is the child who came to you with a complaint of bilateral hearing loss, and you examined the ear, and this was the picture you saw, the fluid level, you saw the air bubbles, and your suspicion increased that yes, this is serous otitis media. Now you want to confirm that this is serous otitis media or not. So now what you do is, yes, you take out your tuning fork. All this you are going to tell me. Yes, Rinis, tell me about, let us say that this is a right serous otitis media. Okay, right, Rinis will be positive or negative? Rinis will be, it is what hearing loss? Conductive hearing loss. So conductive hearing loss, Rinis is negative. Rinis is negative in which two conditions? In conductive hearing loss or in severe sensorineural hearing loss. It is positive in normal and in sensorineural hearing loss. Weber's in right serous otitis media. If it is right serous otitis media, Weber's will be towards which side? Yes, towards the right side. It will be towards the same side. Weber's is towards the same side in conductive hearing loss, and towards the normal side, towards the worst ear in conductive hearing loss, towards the better ear in sensorineural hearing loss. ABC, absolute bone conduction. It is a test to find out conductive hearing loss or sensorineural hearing loss. The name itself tells you absolute bone conduction. It is a test for bone conduction. Bone conduction is sensorineural pathway. So it will be the same as examiner. Same as examiner. This will be towards the same ear or worst ear. That is the worst ear. Yes. Now, usually AB and Schwabach we are not going to do in all patients, but this I am mentioning it again and again so that you revise. Yes, these are questions of your exam, so you should revise again and again. That only makes your memory perfect. So, Schwabach will be Schwabach in sensorineural hearing loss is same as ABC. It is shortened. In conductive hearing loss, it will be lengthened. So, it will be lengthened. Yes, tell me, you get the audiogram done. Will there be AB gap? AB gap. Yes or no? Yes, AB gap means it is conductive hearing loss. So, yes, AB gap will be present. Okay, so now you have confirmed that this is the patient of conductive hearing loss. This is the patient who came to you only with one complaint, and that is hearing loss. So, whenever the patient comes with only one complaint, that is hearing loss, the complete picture of ear comes to your mind. It can be external ear, it can be middle ear, it can be inner ear. Yes or no? Yes. So now you want to localize. So what you did is you did the Rinne's test, you did the Weber's test, which means you did the tuning fork test. What you got was that it is a conductive hearing loss. Rinne's is negative, Weber's is towards the same side. So you saw that this is a conductive hearing loss. So now you confirmed by your audiogram whether it is conductive hearing loss or not. And yes, it is conductive hearing loss. So you have localized, you have ruled out that this cannot be inner ear, it can be external ear, it can be middle ear. And you have already examined the ear of this patient. You already saw that external ear, pinna and external aortic canal were good. So now you have already localized that the disease is where? Yes, the disease is in the middle ear. This is the patient who had hearing loss and conductive hearing loss, and the up till external auditory canal, everything is normal, everything tympanic membrane, everything is normal. So this is a condition of middle ear. Now in the middle ear, now we want to confirm what condition of the middle ear this is. Maybe you are frankly seeing all the air bubbles and the fluid level. It is very diagnostic. Yes, many other times all you see is just a little retracted tympanic membrane, and you want to confirm that this is serous otitis media. How can you confirm? What is the test to find out the function of the middle ear, the condition of the middle ear? Yes, impedance audiometry. So in impedance audiometry, what you will get, tympanometry. Impedance has two parts, tympanometry and stapedial reflex. So tympanometry, yes, what is this? This is fluid. So because of eustachian tube obstruction, the middle ear pressure will be negative. And because of fluid, the tympanic membrane mobility will be less. So this is a negative pressure and reduced mobility. Can you tell me which curve? Yes, this is a B-type curve. All this should be on your tips now. Yes, when you finish the audiology, this should be on your tips. So you will get a B-type of curve. Very, very early cases when the eustachian tube is obstructed, fluid has not yet collected, that is the C-type. So you will get a B-type curve. And this B-type curve is also known as a dome-shaped curve. It is also known as a dome-shaped. And yes, this is how you will see it. The pressure is negative. Yes, the maximum peak is at here. So that is the negative pressure, and the compliance is also reduced. So yes, this is the B or the dome-shaped curve. And we know that impedance audiometry has two parts. What are the two parts of impedance audiometry? Tympanometry and stapedial reflex. What will happen to stapedial reflex? So if we give a 70 decibel sound to test the stapedial reflex in the ear which is affected, what will happen? Yes, because of the conductive hearing loss, before it reaches the inner ear, so much of the sound would have been lost. Maybe a 30 decibel or maybe a 40 decibel is lost. That is the amount of hearing loss. Usually fluid in the middle ear leads to around 30 to 40 decibel hearing loss. So if there is a 30 decibel hearing loss, what will happen? Out of 70, 30 is gone. So only 50 decibel sound reaches the inner ear, and that loudness is not sufficient to elicit a stapedial reflex. So stapedial reflex will be absent. We know stapedial reflex is absent in conductive hearing loss. Now if I tell you, we do not have time to do all these tests. Just do one test and tell me the diagnosis. In other words, which will be the best investigation to confirm serous otitis media? Yes, that will be, best will be tympanometry or impedance audiometry. Can you tell me tympanometry is a objective or a subjective test? It is an objective test. Patient's cooperation is not required. Okay, so now this child, you did all these tests, you did the tympanometry, and you got the B type of curve, and you have confirmed that this is a patient of serous otitis media. What is the cause? The cause, you know, in this child is a mass in the nasopharynx. This mass is a hypertrophied adenoid. So what should we do? Should we ask for an adenoidectomy? Should we ask the child that come and get an adenoidectomy done next week? No. We know that this adenoid hypertrophy is in allergic conditions, and that is what the parents are also telling you. The parents are telling you that for the past 1 week or maybe 5 days, 10 days, the child is having like this, and whenever there is a allergic change in weather, usually the child develops this. Whenever there is any allergy that the child has, the child develops this. So what we can do is, we can do everything to first reduce the size of the adenoid. So always remember, the first management is always a medical management. Surgery is never the first management usually for most of the things. Always try to manage medically. If not possible, then go for surgical management. So the first management is medical management. And in medical management, what are we aiming at? We are aiming at the cause. The cause is the hypertrophied adenoid. So we will give anti-allergics. We will give decongestants. Decongestants, very, very important. We will give nasal steroid spray. So don't think serous otitis media, why we are giving nasal steroid spray. Yes, so nasal steroid spray. Why? To decrease the size of the adenoid. And you give the medical management for at least 3 months. It is not that every patient you have to give for 3 months. You give the patient for a week and you see. If the patient is benefited, stop the drugs whenever you feel that the patient has benefited. But if the patient is not benefiting, how long can you continue the medical management? Maximum for 3 months. Why not more than that? Yes, is this a bilateral condition? Is hearing of both the ears of the child getting affected? Yes, and is hearing important in children? Yes, it is important. Why? Because only when the child will hear, he will learn speech, he will understand speech. So we know, when we know that it is not resolving with a continuous maximum medical management for 3 months, means it is chronic. It is probably not responding to medical management. Now we cannot let the child be with hearing loss for very long. So now what we go for is removing the adenoid. So the surgical management is never the first management. First management is medical. If medical fails, if medical management fails, only then fails, that is after more than 3 months, yes, only then you go for surgical management. And what will be the surgical management? Yes, you will remove the adenoidectomy. Okay, now if you have removed the adenoid, do you think that the eustachian tube which has not functioned chronically for months together will immediately start functioning and the next day the child will be happily hearing? No. The eustachian tube which has not functioned for months together takes time to come back to normal, and this time can be from maybe 1 month, 2 months to maximum 6 months also. So which means that child came to you with which complaint? With hearing loss. You have removed the adenoid also, you have done a surgery also, and after that if the child is not hearing, acceptable? Not at all. Not at all acceptable. So we cannot just remove the adenoid and send the child back. That wait for 6 months maximum, it will be okay. What you have to do is, you have to immediately following surgery, the hearing should be good. So for that, what will we do? Yes, why is the hearing loss? Because of collection of fluid in the middle ear. So what you will do is, you will remove the fluid from the middle ear, and we know whenever there is pus in the middle ear, whenever there is fluid in the middle ear, how do we remove the fluid from the middle ear, pus from the middle ear? By giving an incision on the tympanic membrane. Yes, and tympanic membrane is known as myring. So giving an incision on it will be known as myringotomy. So along with adenoidectomy, you will go for myringotomy. Myringotomy. Okay, so here in this patient, you will also give an incision. You will go for myringotomy. Okay, any other condition you know of where you will going for myringotomy? Yes, tell me. When there was pus in middle ear, what was that condition? In acute otitis media. So is the myringotomy of acute otitis media and serous otitis media the same? No, there is a difference. Why the difference? Yes, just see here. In this condition of serous otitis media, if we just give an incision, just imagine that we have given an incision. Yes, if we have given an incision, suppose we have given an incision anywhere on the tympanic membrane. Okay, now what will happen? The fluid will come out when you are given the incision. Immediately you are operating, that time the fluid will come out. But now the edges will close, edges will approximate, and the edges will close, and the eustachian tube has not yet started functioning. So what will happen? Again fluid will collect, and maybe in 2 or 3 days again the child will have hearing loss. So we cannot just give an incision and that is it. What we have to do is, we will have to replace the function of eustachian tube till the eustachian tube starts functioning again. So only giving an incision will not suffice. Yes, we will have to, along with giving an incision, we will also have to replace the eustachian tube. And how do we replace the eustachian tube function? That is with the help of a device like this, which is open on, it is a tube which is open on both the ends. This we put on the tympanic membrane, and this serves for ventilation and drainage of middle ear, the same function as the function of eustachian tube. So this is what is known as a ventilation tube. Ventilation tube, or it is known as grommet. Now by seeing this picture, you must be thinking that, my God, such a big instrument, such a big device this is. Just see in live how small it appears. Yes, that was a magnified drawing that we saw. So this appears so small. This is a small ventilation tube. Now this is what we will put on the tympanic membrane to replace the function of eustachian tube. So now I have told you one thing, that we are going for adenoidectomy, we are going for myringotomy, and not only myringotomy, along with that we are also giving a grommet, a ventilation tube. Now what you are going to tell me is that if I want to put a grommet, how should be the incision of the tympanic membrane? If I give a curvilinear incision like this, if I give a big incision like this, we just saw how minute the grommet is. Yes, will it stay there? No. it will get extruded or it will get intruded. It will go into the middle ear or it will come out into the external auditory canal. If we want to put the grommet, such minute, we want it to be held very tightly by the fibers of the tympanic membrane. It has to stay there for at least 6 months. So if we want to be to be held very tightly by the fibers of the tympanic membrane, which means the incision should be radial. So that the moment you give the incision, we know that these fibers will not stay like this, it will snap back. So they will then hold this grommet very tightly. And in which quadrant will we give? Yes, a eustachian tube is what we are replacing with the help of grommet, and eustachian tube is present on which wall? Anterior wall. So we will put it in the anterior and inferior quadrant. That is exactly where the eustachian tube is, so that it maximally mimics the eustachian tube. So we give a incision that is antero-inferior like this, and it is radial. So it is a radial and antero-inferior incision. Radial in the antero-inferior quadrant. So this is the same instrument, the myringotome, which we use to do myringotomy, to give the incision on the tympanic membrane. And yes, what is the difference now? You will tell me. In acute otitis media, the site of incision is posterior-inferior. Here it is antero-inferior. Yes, see, because posterior-inferior, because that was most accessible. Here antero-inferior, because this mimics the eustachian tube maximum. That is where eustachian tube is present. Shape, tell me the shape of incision. Here it is curvilinear, and here it is radial. Yes, why radial we know, why curvilinear we know. And grommet is put? No, not in acute otitis media. Yes, in serous otitis media. So when you put it, this is how it appears. Now many times what happens is that the fluid that is collected in the middle ear is very, very thick. So when you give the incision, what you do is you first suction out all the fluid and then you put the grommet for ventilation. Yes. So now if the fluid is very, very thick, when you're suctioning out, it is not coming out. It is very difficult to suction out. In that case, what you do is you give a incision in the antero-superior quadrant. Also, along with the antero-inferior quadrant, you have given an incision here in the antero-inferior quadrant. Along with that, you give an incision in the antero-superior quadrant also, because the fluid is not able to get suctioned out because it is very thick. So now what happens because of this? Yes, this upper opening, through the upper opening, air enters inside the middle ear and it pushes the fluid out through the lower opening. This is what is known as Beer-Can technique. Beer-Can technique. Yes, so why beer can? Yes, we know that whenever we open the can of the beer, what happens is the air, yes, you shake it and you open it, the air enters and it pushes the fluid out. So that is what is the beer can technique. So can you tell me myringotomy is never done in which quadrant? Never in which quadrant? Yes, it is never in the posterior-superior quadrant. Why never in the posterior-superior quadrant? We already saw earlier that in the posterior-superior quadrant, we have all the important structures. We have the incus, we have the stapes, we have the oval window. All these important structures are present in the posterior-superior quadrant. So myringotomy is never in the posterior-superior quadrant. Now, when we have to put the grommet, usually the most common grommet that we put is the one that stays there for around 6 months' time. During this time, the eustachian tube regains its function and this grommet is no more needed now. So this grommet, which is for a short term, is what is known as short-term grommet, and it is shaped like this, as you can see here. There are two named short-term grommet, Shepherd and Donaldson's. So yes, just remember the names of the short-term grommet. Now, if the eustachian tube in any child is chronically obstructed, in any patient, if it is a chronic obstruction of the eustachian tube, we know how to find out that. Yes, we know that the retraction of the tympanic membrane, if it's a chronic obstruction, goes from first stage to later on stages to stage 2. Stage 3 becomes, what is stage 3 retraction known as? Yes, there is no air, collapsed middle ear cavity, that is atelectasis, and stage 4 is adhesive otitis media. So if it is a chronic obstruction of the eustachian tube, then we know that the eustachian tube is not functioning properly and we will have to replace the function of eustachian tube for a little longer. So in that case, we go for a little longer term grommet. which can stay from 2 months to from 6 months to around 2 years, and they are shaped like this. Just see the shape. Yes, how the shape is, it is protruded at one end. So when you put it inside like this on the tympanic membrane, this is the part which is staying inside. It will not be very easy for it to come out, so it will stay for a long time. So these are Shah and Armstrong grommet. And for people who have a very, very chronically obstructed eustachian tube, you use something like a copper T. The grommet looks like this. It's not a copper T. There's a grommet which looks like a copper T. This is what is known as T tube. This is known as T tube, and it stays for more than 2 years. So these are the different types of grommets that we can use. Usually the most common that we use is the short-term grommet, which stays for less than 6 months. And after 6 months, do we have to remove the grommet, or does it get extruded by its own? What do you think? Is gradually it goes on getting pushed outside and outside, and usually in 6 months time the short-term grommet get extruded by itself. That has been a question of your exam, that you have to remove the grommet after 6 months. No, you don't have to remove. It will come out by itself. And can you see here, it has come out by itself, and the opening also, it usually closes by itself. So you do not have to do anything. Only you can call the patient after 6 months and you can see whether it has come out or not. If it is lying in the external aortic canal, you can remove it. Otherwise, mostly the patients might tell you that yes, on the pillow they saw a small tube, because that is what you informed them earlier also, that it will come out by itself. So maybe you will find it on the pillow or in the external aortic canal. You will see some white thing. Don't panic. It is the grommet. It is supposed to come out. It will come out. Okay, so now you are going to sit straight. Yes, keep your pens down. Sit straight. Okay, now tell me, when will you think of serous otitis media? In which patient will you think of serous otitis media? What will be the complaint of the patient that will immediately make you think that yes, serous otitis media should be ruled out in any child? Tell me child, yes? Okay, bilateral, painless, what else? Fluctuating conductive hearing loss, or maybe delayed speech development. So here is a child in front of you with bilateral conductive hearing loss. Yes, you are suspecting serous otitis media. If this is serous otitis media, what will be the appearance of tympanic membrane? Yes, dull and retracted tympanic membrane. Bluish tympanic membrane is a feature of, yes, serous otitis media. What are the characteristics of a retracted tympanic membrane? Stage 1 retraction of tympanic membrane. Yes, cone of light will be absent or distorted. The handle of Malleus will be foreshortened. The lateral process of Malleus will be prominent. Sickling of the malleolar folds. So what test will confirm that this is a serous otitis media? Which is the best investigation to confirm serous otitis media? Yes, tympanometry. What curve on tympanometry will tell you that this is serous otitis media? Which graph? B-type curve. What is B-type curve? What is compliance in B-type curve? Reduce. What is middle ear pressure in B-type curve? Yes, it is reduced. So you have confirmed that this is a patient of serous otitis media. What will be your line of management? Will you immediately post the patient for adenoidectomy? Yes, no. Yes, was a question of your exam that the first management of serous otitis media is, yes, it is medical. Has been asked again. Medical management is given for how long in serous otitis media? For how long? Yes, for at least for 3 months. So you give medical management for 3 months, aiming to reduce the size of the adenoids. Okay, not benefited. Now, adenoidectomy with myringotomy with grommet. Was a question of your exam that what is the management of serous otitis media not benefiting by medical management, or surgical management of serous otitis media is, and the choices was myringotomy with grommet, adenoidectomy with grommet. Yes, what do you think will be the best answer here? Obviously, adenoidectomy with grommet. If you are putting a grommet, it is understood you would have done a myringotomy. Yes, what is the myringotomy done in ASOM, in acute otitis media? Where is the myringotomy done? Which quadrant? Yes, in the posterior quadrant. Grommet is put in which quadrant in acute otitis media? Grommet is put in which quadrant in acute otitis media? Grommet put in acute otitis media? Yes or no? Never. Grommet is put in which condition? In serous otitis media. Grommet is not put in acute otitis media. In serous otitis media, grommet, what does grommet do? Replaces the eustachian tube. So grommet is put in which condition? In serous otitis media. It is put in which quadrant in serous otitis media? In antero-inferior quadrant. Tell me the shape of incision for grommet. It is a radial incision in the anteroinferior quadrant. So this is a patient of bilateral serous otitis media where myringotomy was done in both the ears, and this is the right ear that is being shown to you. Let me orient you first. So that this we are seeing this is the superior part, this is the lateral process of malleus. Below there you can see the handle of the malleus, and you can see the malleolar fold which is very prominent. The tympanic membrane is appearing retracted. The tympanic membrane is dull, and yes, you can also see that there is some fluid behind the tympanic membrane. So now the myringotome will be put inside and an incision will be given. And yes, I want to ask you that if we are giving myringotomy incision for serous otitis media, it should be in which quadrant? Yes, it has to be anterior. So that is the anterior part. This is the posterior part. So it should be done anteriorly and inferiorly. And what should be the shape of the incision? Yes, it has to be a radial incision. So now let us start seeing how the myringotomy is being done. So the myringotome is being passed and a radial incision will be made in the anteroinferior quadrant. So we can see here that a radial incision is being made. As you can see how sharp the knife is. So that is why this is never done in the posterior superior quadrant for chance of injury to all the important structures of the middle ear. So if you are passing this sharp knife, all those can be damaged. So here we are seeing the thick glue-like fluid coming out, being suctioned out. And all of that has been suctioned down. That is why this is also known as the glue ear. And now we are putting this grommet. This is how the short-term grommet looks like. And this is being done endoscopically. No incision has been given anywhere else except for the myringotomy incision on the tympanic membrane. We can see that the radial incision has held the grommet so tightly, so this can stay in its place. So it will suffice the function of the eustachian tube, which is the ventilation and the drainage of the middle ear, till the eustachian tube regains its function. So here's a child who came to me with a complaint of bilateral hearing loss, and yes, this is the tympanometric finding. Tell me the diagnosis. What are you seeing on tympanometry? Bilateral, what curve is this? B. What is this? B. Yes. So this is a serous otitis media, and yes, are we expecting serous otitis media to be bilateral in children? Yes or no? Yes. Now this is the tympanogram finding of an adult who has come with hearing loss. And the tympanic membrane is intact. Tympanometry, that is when tympanometry is done. Yes, when the tympanic membrane is intact. So here what are you seeing here? What is the finding of the tympanometry? This is a A-type curve. A-type curve, I told you A-type curve you can remember by seeing what the compliance is. Compliance is in between 0.35 to 1.45, or more or less what you can remember is that just remember that the peak of the graph is somewhere in the middle. Somewhere in the middle, not exactly in the middle, little above, little less. So somewhere in the middle of the graph, that is the A-type curve. So this is the A-type curve, and what is this? This is a B-type curve. So in this patient, there is a unilateral serous otitis media. Tell me, an adult. This is a adult with unilateral serous otitis media. What are you going to rule out in this adult? Yes, very good. Nasopharyngeal carcinoma. You have to rule out. Go for a nasopharyngeal endoscopy and rule out nasopharyngeal carcinoma. So now let us quickly have a look at the surgery of grommet insertion in a patient of serous otitis media. Now a quick word about otitic barotrauma. Now what is barotrauma? We already know that pressure-related changes, pressure-related damage, trauma is what is known as barotrauma. Baro is pressure and trauma. Trauma because of pressure changes is barotrauma. And otitic, that is relating to the ear. So the trauma to the ear because of pressure changes is what is otitic barotrauma. And pressure changes leading to ear trauma is what is otitic barotrauma. Now, otitic barotrauma, where do we see it very commonly? Very good. We deal with it very, very commonly nowadays. Yes, whenever we fly, whenever we are flying, whenever during ascent and during descent. Okay, now for understanding what happens during ascent and what happens during descent and why barotrauma occurs, we first need to know that in our body, there is the fluid compartment which consists of the blood vessels and the CSF. Whenever there are external pressure changes, the fluid compartment inside the body automatically gets regulated to that pressure. If it is a negative pressure, when we go up, all the fluid compartment in the body gets changed to the same pressure as outside, that is the negative pressure. And the pressure becomes the same whether it is inside the body or the out. Same happens when we come down, when the pressure increases. But in all the compartments of our body where there is air, like in the middle ear or in the sinuses or in the lungs, the pressure does not equilibrate by itself. The pressure will equilibrate to the external ambient pressure in these air-filled compartments only when the air of that pressure will enter these compartments. So what is the problem? Whenever we are breathing, air is entering the sinuses, air is entering through the eustachian tube to the middle ear, air is going into the lungs. So wonderful, that will also get equilibrated. Whenever we are going up and down, it is not that we have stopped breathing, we are breathing, right? So the air-filled compartments also will get equilibrated to the outside pressure. But there is a problem. Here, let us concentrate on the ear. Yes, we are doing the otitic barotrauma. Now, if the eustachian tube is blocked, then this will not be possible. And that is when the pressure-related damage will occur to the ear, which means that whenever you are flying, be careful not to fly whenever you have a pharyngitis, whenever you have a sinusitis, whenever you have a eustachian tube blockade. Yes, it means that get it treated before you know that you are going to fly. Otherwise, there will be otitic barotrauma. So now let us see what happens during ascent and what happens during descent. Now let us see the first scene, that is during ascent. Now what happens during ascent? As we go up, the pressure of the air as we go higher and higher becomes less. So the outside pressure means the pressure in the external auditory canal, the pressure in the nasopharynx, the pressure in the fluid compartment in the inner ear, in the blood vessels, everything is negative. Yes. So right now when we are ascending, the pressure outside is negative and inside the middle ear it is positive, which means that in the middle ear the pressure is more. So what will happen when the pressure will become more? Yes, so now once the pressure in the middle ear crosses 15 mm of Hg, it becomes 15 mm of Hg more than the outside. Now it will push open the eustachian tube. Okay, the eustachian tube will get pushed open and air will exit from here, and this air will now enter and the pressure will get equilibrated as the same as outside pressure. That is good. That happens in normal ears. But suppose if the eustachian tube is blocked. So if the eustachian tube is blocked, now what happens? Yes, eustachian tube is blocked. Yes. So now what happens is that the pressure that is increased here, this is not able to go out through the eustachian tube. So where will it put pressure? Yes, it will put pressure on the tympanic membrane. Yes or no? Tympanic membrane will bulge out. When the tympanic membrane bulges out, the ossicular chain will get stretched. If the pressure increases more and that will happen when the flight is going more higher, and if the pressure outside becomes more negative, the more positive it will become inside the middle ear. So now tympanic membrane will bulge more, and that can lead to tympanic membrane perforation. Also, because of the tympanic membrane bulging more and more, the ossicular chain is getting stretched. Yes, so the oval window is getting pushed out and the round window is getting pushed inside. We know that both the windows, the pressure is opposite. So as it is getting pushed out, this is getting pushed in. That can also lead to round window rupture. Round window rupture, that can lead to perilymphatic fistula. Perilymphatic fistula. Patient will have a sudden onset of vertigo. Very severe pain, and following that patient will have a sudden onset of vertigo. Yes. So now let us see what happens during descent. Now, during descent, usually the trauma that occurs is more common during descent. Why? What happens during descent is, now when we are coming down, the pressure, the lower pressure, as we come down, the pressure of the outside air is more. So here the pressure is more. Pressure is more here. And inside, the pressure is less. So in normal years, what will happen when the pressure is more outside and the pressure is less inside? So what we do is during descent, when we swallow, when we chew, that is why in flight earlier, now they don't give, but yes, earlier they used to give chewing gum or they used to give toffees, that during descent you have to swallow it, and during ascent also you have to swallow it. So when during descent, when you are just chewing, or when you are swallowing with swallowing movement or with chewing movement, what happens is that the eustachian tube opens. When the eustachian tube opens, the air will enter into the middle ear and that will get equilibrated. But what if the eustachian tube is blocked? If this is a patient who is traveling with a sinusitis, with a pharyngitis where the eustachian tube is blocked, now the pressure of the middle ear is negative and this air is not able to enter into the middle ear. The pressure will go on becoming negative, negative, negative. More here, it will be becoming positive. And now it will push the tympanic membrane inside. The tympanic membrane will push inside. Along with that will be pushed the oval window inside. And because of increased pressure of the perilymph and the blood vessels here, the round window will be pushed outside. So what will happen? Now, as the tympanic membrane is getting pushed inside, it can rupture. The oval window is getting pushed inside and the round window is getting pushed outside, it will rupture. So this can also lead to tympanic membrane rupture. This can lead to round window rupture. That can lead to perilymphatic fistula again. Yes, and also the increased pressure of the blood vessels here and the more of the negative pressure of the middle ear will lead to damage of the blood vessels and a hemotympanum also. Blood, hemotympanum. My God, so many things just because of flying with a clogged eustachian tube. Yes, these can happen when the eustachian tube is open, when the pressure changes are very sudden, when the weather changes are very bad, and from a very high pressure, suddenly the pressure becomes very low and the time is not there for the equilibration of the pressure to occur. So then also these changes can occur. And this is how the tympanic membrane might appear. This is a very little damage that is being seen here. It can be very severe also. Here we can see tympanic membrane has ruptured. We can see there is bleeding on the tympanic membrane, the rupture of the blood vessels of the tympanic membrane. There can be collection of fluid in the middle ear. There can be collection of blood in the middle ear. So for all this, the best is prevention. Management, best is prevention. Second, yes, by chance if there is, you have to fly with a running nose or with a cold, then always you can put decongestant nasal drops before traveling so that that area is decongested. Definitely, little changes might occur, but it would not be so severe. And second is, if at all the patient has developed, then what you can do is you can give him methods to inflate the middle ear. For example, you can ask the patient to do a Valsalva. You can go for polysterization. We know what it is. We have seen the eustachian tube functions. Yes, we can go for eustachian tube catheterization, where we actively we force air into the eustachian tube, through the eustachian tube into the middle ear, so that the pressure becomes equilibrated and all the retraction of the tympanic membrane will become normal. The eustachian tube will become normal. So this is eustachian tube catheterization. Definitely you are going to treat whatever has led to the eustachian tube obstruction, and if at all nothing is possible, all these does not work, then in that case you can go for a myringotomy to drain the fluid and the blood from the middle ear. Myringotomy. Yes, so you are going to tell me now quickly that barotrauma. What is barotrauma? Yes, that is damage to the middle ear because of pressure changes. That occurs more during ascent or descent. It can occur both during ascent or descent. By chance both is there in the choice, what will you mark? Ascent or descent? Yes, it is more common during descent. Can a barotrauma lead to perilymphatic fistula? Can it lead to round window rupture? Yes or no? Yes. Can it lead to a perforation of the tympanic membrane? Yes, it can lead to. Yes, so what you have to do is never fly with a clogged tympanic membrane. So whenever a patient comes with this complaint, only decreased hearing, he has no complaint of pain in the ear, no complaint of discharge from the ear. So now the whole ear comes to our mind. It can be either external ear, it can be middle ear, or it can be inner ear, because hearing loss can occur because of defect anywhere in the pathway. If it was associated with pain or with discharge, then we would have localized that the inner ear is ruled out, and now it is either the external ear or the middle ear. But now he has only one complaint, and that is the complaint of hearing loss for the past few months, and that is only in his left ear. So how should we approach? Tell me, what will you do when the patient is here who is telling you only hearing loss? Yes, now our aim is to localize the lesion, whether it is external ear, middle ear, or inner ear. We know that external ear and apical tympanic membrane we can very easily visualize. Yes, so you will immediately not jump on doing some tests. First thing is you will examine the ear. So yes, you take your otoscope. So here is a patient who has come to me with a complaint of decreased hearing in his left ear for the past few months. So the moment he says decreased hearing, and he is giving no other history, no history of pain, no history of ear discharge, only decreased hearing. So had he been giving any history of ear discharge or pain, I would know that the inner ear is spared. Inner ear is not involved. It is either the external ear or the middle ear, but now only hearing loss. So now the complete ear comes to our mind. It can be either external ear or middle ear or inner ear, and now we want to localize where it is. So yes, we know that what we can do is we can immediately examine and we can rule out the external ear. The external auditory canal, the pinna, the tympanic membrane, that is something which is very easily visible to us. Yes. So why not just examine first? We are not going to jump first on doing any test. First examine the ear. You will come to know whether it is the external ear, and then you need not go for any test. So what we do is we take the otoscope, and yes, this is the ear speculum. I am going to use the largest ear speculum which will fit his external auditory canal. And how should I pull his pinna to make his external auditory canal a straight line? Yes, posteriorly and superiorly. So this is how I'm going to pull the pinna. And yes, I'm going to have a look at his external auditory canal. The pinna is good. Okay, so his pinna is good. His external auditory canal looks perfect. The tympanic membrane is appearing a little retracted. So now I want to confirm whether it is the middle ear or not. How can I do that? Yes, I can do it by finding out whether it is a conductive hearing loss that he is having, or he is having a sensorial hearing loss. That will confirm, if it's a conductive hearing loss, that he is having defect in the middle ear. So for that, what we are going to do is we are going to do the tuning fork test. So have you got it now? That whenever the patient comes with hearing loss, if I was able to find some defect in the pinna or the external auditory canal, or if by the tympanic membrane was very congested and I could make out it is acute otitis media, I wouldn't have needed this tuning fork. I would have made the diagnosis what it was and I would have treated the patient. But now the tympanic membrane is a little retracted. I'm not very sure whether it is the middle ear or not. Now I want to confirm. So now I will use a tuning fork to confirm it is a conductive or a sensorial hearing loss. If it is conductive, I'm sure it is middle ear. So now you first will have to explain the test to the patient. So before I explain the test to the patient, I'm just going to show you how we are going to do this test. So what we are going to do here is we are going to do the Rinne's and the Weber's. So in Rinne's, we are going to test the air conduction and the bone conduction. For that, we first have to vibrate the tuning fork. How do we vibrate the tuning fork? Is either by hitting it at the elbow or by hitting it at the knee. Can we also hit it at the table? That will produce a very nice loud sound. No, it is never done at the table. It will produce overtones which will give you false results. You can also hit it against a hard rubber pad, but never against a hard surface like a table. So when you vibrate the tuning fork, what you do first is you place the tuning fork. Either you can place it either parallel or perpendicular to the external auditory canal, around 2.5 centimeters away from the external auditory canal opening, external acoustic meatus. Some books mention that you have to place it parallel. Some books mention you have to place it perpendicular. Now Scott Brown clearly mentions that either can be done. And what you are testing here is the air conduction. And how do you test the bone conduction is, again, you vibrate the tuning fork and you place it over the mastoid. Where exactly on the mastoid you place the tuning fork is at the non-hair bearing area posterior superior to the canal. Posterior superior to the canal at the non-hair bearing area. And when you are doing this, you usually hold the head so that the patient does not move to the opposite side and the compression is adequate. And before you do the test, you explain the test to the patient. So now I am going to do this test. I will place this instrument first in front of your ear. This is 1. And then I will place it behind your ear. This is 2. You have to tell me whether you are hearing 1 as loud or you are hearing 2 as loud. Now sit straight. I vibrate the tuning fork. Can you hear? Did you hear the second?
Second one more.
Second was more?
More.
Okay. So now what we did is we did the air conduction and then we did the bone conduction. And the patient is telling me that the second, that is the bone conduction, was more. So the bone conduction is better than the air conduction in this patient. So it indicates that Reni's is negative. Now Reni's is negative in which two conditions? Either conductive hearing loss or a severe sensorineural hearing loss. So how are we going to rule out? How are we going to confirm? Yes, by Weber's. Now I am going to place this over your forehead here. And you have to tell me whether you are hearing this sound equally all over your head or you are hearing it louder in any ear. So now I vibrate it. And for Weber's, either you can place it over the forehead here or you can place it at the root of the nose, the bridge of the nose, or you can place it over the teeth. Or also in bald patients, you can place it over the vertex like this. Yes. So now I'm going to place it here and I'm going to ask him. I've explained it already to him. Did you hear it?
Yes.
Was it louder in any ear?
Left one.
Left ear. So now the patient is telling me that he is hearing the sound louder in this ear. So we already, the Reni's was negative, so it was a conductive hearing loss. The defect is in this ear. He's telling he has hearing loss in this ear. This is the worst ear, and the Weber's is localized. It is lateralized to the worst ear. So this is telling us that in the left ear, the patient has a conductive hearing loss. So now I have confirmed that the defect in this patient is in the middle ear. Now in the middle ear, the defect can be anything. It can be ossicular discontinuity. It can be ossicular fixation. It can be just a fluid in the middle ear. By the appearance of his tympanic membrane, it is a little retractor. I feel that this can be a fluid in the middle ear. This can be a patient of serous otitis media. So now what test am I going to do for confirming that it is a serous otitis media, for confirming what defect in the middle ear it is, for localizing further what is the defect so that I can treat him accordingly? Yes, tympanometry. So I got his tympanometry done. So here is his tympanogram. The right ear is normal and the left ear shows a B type of curve. So yes, we have confirmed now that in his left ear, the diagnosis is a serous otitis media. Stapedial reflex is negative in the left ear. So what is coming to your mind? Was it a child? Will you think of adenoid? Anyway, adenoid leads to bilateral. So this cannot be adenoid. This is a unilateral serous otitis media that the patient is having. So he should be investigated for a nasopharyngeal mass, which can be a nasopharyngeal carcinoma. Is that clear? So this is how your process of thinking should be whenever a patient has come with hearing loss. Had it been a sensorineural hearing loss, then you would have thought on the lines of a sensorineural, the causes of sensorineural hearing loss.